Hey everybody, it's Dr. Gilchrist, and as promised, I am recording this section on chronic illness, terminal illness, and death, just to make sure that you are prepared for our exam coming up on Tuesday. So that's obviously not very far away. So to make sure that we cover this, I'm going to go through all of these slides. Where possible, I have also brought in additional details that are a little bit more recent than the textbook. So the last time that we were here, we talked about the fact that chronic illness is basically a byproduct of the fact that you and I in general have much longer lives. As reported in your textbook, and I didn't mention this last time, back during the Roman Empire, which would be about 100 AD or 100 Common Era, most people lived between 20 and 25 years old. Generally, if you were born in 2010, you will probably live about 81 years if you're 81 years if you're female, and 76 years if you're male. Now, this has changed a little bit in light of the pandemic. In fact, this textbook was written pre-pandemic. The pandemic and some of the behaviors that we adopted during the pandemic, as well as things that have gotten worse since the pandemic, like driving, have worked together to basically temporarily shorten our life expectancy. But now I want to talk a little bit about the prevalence of chronic illness. Generally, the most current major causes of death besides COVID include heart disease, various types of cancers, lower respiratory disease, which would include things like pneumonia, cerebrovascular diseases, which would include things like strokes, and accidents. In terms of sheer prevalence, many Americans have some type of cardiovascular disease. In 2020, that was estimated to be about 20.1 million. And just as a friendly reminder, the United States currently has about 333 million people. So 20.1 million is not a small number. Many Americans, almost half, have high blood pressure. In 2020, it was estimated that about 116 million do. 7 million people have had strokes or are stroke survivors, and it is estimated that 1 in 4 of us will have a stroke at some point in our lives. 12 million have had cancer, and in 2021, there were 1.9 million new diagnoses estimated. This may have, again, also changed with the pandemic due to the fact that very few people were willing to go to hospitals during the worst of the pandemic. In fact, we're still trying to catch up with care and treatment for chronic illness during the pandemic. Additionally, diabetes is also very common. It occurs in about 37.3 million. We are not making a distinction between type 1 and type 2 here. And complications of diabetes, in addition to neuropathy, damage to the nerves, you can also get heart disease and stroke. Your textbook has life expectancies across age, race, and sex. Based from 2009 and 2010, be aware that these are going to change based with time. So here's just another way of looking at the prevalence rates of common chronic illnesses, and we are including mental disorders as chronic illnesses because I know that this was something that Luca brought up in class the other day. So, cases avoided if an alternative path is taken. So if preventative care or treatments are available, this is how much we would cut. These are basically the projected levels of chronic diseases by the year 2023. This was originally developed, obviously, prior to that. Stroke, you can see that there are so this is numbers of cases in 2023. These are based out of the thousands. So when you see 40,000, they are not actually saying it in this particular case. So heart disease, hypertension, diabetes, pulmonary conditions, which would include things like COPD, emphysema, things that are occasionally related to smoking as well, and then different types of cancers. And you can see in general that hypertension, mental disorders, and pulmonary conditions are probably some of the most prevalent conditions. What I would also mention is that along with heart disease, there is a sizable proportion of those numbers that can be cut if alternative paths are taken, such as different types of preventative care, regular checkups, lifestyle modifications, and so on. Now, I want to talk a little bit about adjusting to chronic illness. So obviously, preventative care is always going to be beneficial. Changing your lifestyle can absolutely help prevent chronic illnesses, but they are not guarantees. So when we talk about chronic illness, one thing that I will mention is that while treatment of many of these diseases and illnesses have gotten better, there are still not cures for all of them. So we've had advances in cancer treatment. We've had advances in treatments for people with AIDS. Those are not the immediate sudden death sentences that they used to be. However, a lot of these illnesses do not have cures. And so treatment is not going to be based on curing the illness or returning somebody to their perfectly healthy state. The goal of treatment is to get people to positively adjust to these issues and have a positive quality of life, even if it's not 100% what it was. So many chronic illnesses are not curable yet. And I put that in question marks because some of those things will change with time. So as I've mentioned, the goal of treatment will be to help people adjust to these different illnesses as much as possible. So when we talk about adjustment, there are a lot of ways to think about adjustment. Think about some of the different ways that a chronic illness might potentially affect your life. It might hurt your ability to do the daily tasks that you need to do, like do your job or take care of your kids or take care of your house, run errands and things like that. So it can hurt your ability to do those daily tasks. Oftentimes, a lot of people with chronic illnesses will struggle with different psychological disorders, including depression and anxiety, and those are quite common. Additionally, a lot of time when you're dealing with chronic illness, you may experience a low mood or a negative affect. So you are no longer as able to have that positive affect. Additionally, you may not be able to function as well as you could. Maybe moving around is difficult, or talking with others is difficult. Possibly even feeding yourself is becoming more difficult. And then finally, feeling like you're satisfied with life. Obviously, you can see how chronic illness might temporarily take that away from you. So the goal of treatment is to basically do the opposite of all of the things that chronic illness will disrupt. So basically, good adjustment, positive adjustment, basically means you're able to perform your daily tasks. You're able to cope with your chronic illness without resulting in psychological disorders. Or if you have those disorders because of your chronic illness, you learn how to manage your emotions, your thoughts, and your feelings more effectively. You have a more positive affect than you did before. You're able to generally function in various areas, and you feel a little bit more satisfied with your life, even if you're not 100% there. And that's really the goal of adjustment. Now, generally, if we want to figure out how somebody's coping with their illness, we are going to look at something called quality of life, QOL. And this is a pretty common metric to measure coping. This was originally developed by physicians to basically estimate the quality of life in their patients. And what's wild to me is that it was actually pretty straightforward. Do you have a disease? Then you have a poor quality of life. Do you not have a disease? Then you must have a good quality of life. And I'm sure that you can think of examples of people in your life who have different types of diseases or illnesses, And despite all of that, they seem like they're in pretty good spirits. Likewise, you probably know somebody who's not sick but has a pretty horrible quality of life. So now we tend to believe that it is patients that are going to be the best judges of their own quality of life. You can, again, if you want to figure out how your patients are doing, how much pain they're experiencing, how their mental health is, one of the best things you can do is ask them. So let's talk a little bit about some of the different quality of life measures that are out there. So quality of life, first of all, includes a few different major components. So first of all, we need to consider your physical status. Like, how's your physical health? How is your physical functioning? Again, are you able to move around easily? How's your mobility? Are you able to move your body around if you want to go for a walk or things like that? Are you having difficulty breathing? Is it a struggle for you to get a breath? We can focus on your psychological status. How is your well-being? How is your mental health? Your social functioning. Odds are pretty good if you're dealing with a chronic illness of some kind, your social life, the relationships with your friends, your family, your coworkers, that's probably going to take a little bit of a hit. And then finally, another metric of quality of life is presence of symptoms, either from the treatment itself, because some treatments will cause bodily problems, or symptoms from the disease. So all of these things will factor into somebody's thoughts about their quality of life. Now, this is obviously not a perfect measure, and when we're talking about quality of life from a patient perspective, it is pretty subjective. So your book talks about a few different instruments, and I actually was able to find a few for you as well. So I'm going to go ahead and pull those up right now. So the first one that I pulled up, that is that first link in your slides, is the World Health Organization's Quality of Life. So this is the user manual. It is going to take its sweet time pulling up, but you have some of the different instruments and things like that, and some of the different questions that will be included. So if you look in the appendices, you are actually able to find it. So obviously we're not going to go through this questionnaire item by item, but what I did want to show you were some of the different domains that are included in this metric of quality of life. So you get a variety of questions in different domains, including physical capacity. So I've mostly been talking about physical functioning as mobility, but it's more than just that. So we have physical capacity. We're going to talk about pain measures, energy levels, which would also be considered a form of physical functioning, and then sleep and rest. We have psychological aspects related to positive feelings, thinking, learning, memory, and concentration, self-esteem, body image, and negative feelings. We have level of independence, which mobility would also qualify for that, along with a type of physical functioning, activities of daily living, dependence on medication or treatments, and work capacity. We have social relationships, and we have environment, physical safety, financial resources, and then finally, spirituality, religion, and personal beliefs. So very, very early on in the semester, we talked about what health is, and I think it's really interesting that the World Health Organization's Quality of Life questionnaire does include a metric for spiritual quality of life. Now I'm moving on to the CDC's Health Quality of Life questionnaire. So we have a very general rating of health here. Would you say your general health is this? Thinking about your physical health, how many days during the past 30 days was your physical health not good? That includes physical illness and injury. Thinking about your mental health, which includes stress, depression, and problems with emotions. For how many days for the past 30 days was your mental health not good? How many days did poor or physical or mental health keep you from doing your usual daily activities? And then also talking about activity limitations and healthy days symptoms. So pain, emotional problems, anxiety, and things like that. So this one feels a bit more general and isn't really covering as many domains as the World Health Organization's is. And there are a lot of other tools out there for this. I actually managed to find a quality of life one specifically for cancer. So these different quality of life measures are out there. Now, illness is primarily a physiological or biological phenomenon, but how you cope with illness is biopsychosocial. So we have to talk about some of the biological factors, and we're also going to spend a lot of time on the psychological factors. So first of all, when we talk about the different biological factors, different illnesses in general are going to have different biological effects. So for example, cancer is associated with the abnormal growth of unhealthy mutated cells. That's what cancer is. It is an unhealthy mutation. And generally, the treatment is going to be to either destroy those cancers through a chemical means like chemotherapy, or by cutting it out either surgically or with a laser or with radiation therapy. On the other hand, a very different chronic illness is Alzheimer's disease. Whereas cancer is associated with abnormal growth, Alzheimer's is associated with abnormal atrophy and death of cells. So ideally, an Alzheimer's treatment, you would want to try to stop that atrophy of neurons through trying to either prevent plaques of beta amyloid or removing those neurofibrillary tangles of tau protein. And whereas cancer has a variety of different types of treatments, Alzheimer's does not. Many of the medications that are recommended for Alzheimer's do not actually slow down or slow the progression of the disease. Right now, there is no cure. So illnesses are going to have different biological effects, and the treatments that are available to you may vary based on the nature of the illness itself. Now, what about our psychological factors? So the thing is, when you're dealing with a chronic illness, this is going to affect all areas of your life. This is going to affect your mood, it's going to affect your behavior, and it's going to affect the thoughts that you have about this illness. For a lot of people, their lifestyle is going to change. Not necessarily because of anything other than trying to fight this illness is going to affect how you live your life. You may have to change it to accommodate the nature of the illness or to accommodate the treatment that you have. Additionally, many people in your life are going to have to deal with this you that is dealing with this reality, and some of them might even be your caregivers, which means that in addition to all of the adjustments that you're making with yourself, you're going to have to make adjustments in each of these relationships. Now, our ability to cope is affected by our primary appraisal and our secondary appraisal. Lazarus talked about this in his theories of stress. And just as a reminder, our primary appraisal is basically whether we view what's happening to us as a threat, something that can cause us harm, or something that is challenging. And then once we've made that primary appraisal, we have a secondary appraisal, which is basically, do we have the resources to actually cope with what is going on with us? So generally, what we're going to find is that if you see the illness as something that is challenging and you have a lot of social support, you have the resources to cope, or you have the finances to afford treatment, you are generally going to have a higher quality of life. Generally, just to kind of give you an example, your book talks about colorectal cancer patients. And colon cancer and rectal cancer is very debilitating. What they ended up finding is that people who basically appraised it as a threat, something that's threatening, that actually affected their quality of life up to 2 years after their treatment. So this will affect your coping, and it can even actually affect your health. Now, psychologically, what are some very common responses that people tend to have with chronic illness? And this is actually going to be one of your exam questions. So denial is probably going to be the first major feeling that you're going to have when you are informed that you have a chronic illness. Most people may try to block it out because it doesn't feel real. And generally, denial can actually work over the short term because it reduces the anxiety of getting this diagnosis. But it's pretty bad over the long term. It's associated with lower adherence to treatment, and it's associated with delays in reporting and getting the treatment that you need. So denial can work over the short term, and it's pretty common, but it fails over the long term. Now, another common reaction that we might have is anxiety. And generally, anxiety often leads to poorer coping, and it's also going to lead to delaying actually reporting symptoms. Now, part of the reason that anxiety tends to happen in chronic illness is usually during periods of uncertainty. Are you waiting for test results? Are you waiting for a diagnosis? Are you waiting for a medical procedure? So oftentimes anxiety is going to be high under those periods of uncertainty. Another time that anxiety is going to be really common is when you don't get a lot of information about your illness. If there's a lot that you don't understand about your illness, and that can be really scary if this is something you don't know that much about. And what we do know is that in some ethnic groups, and for those that have lower socioeconomic status, a lot of those groups do report getting that information-induced anxiety because they don't know what to expect. They don't know what's coming next. And then finally, the most common negative reaction to chronic illness is depression. Generally, anxiety tends to be a short-term reaction and basically prompted by very specific instances of uncertainty or waiting. Depression is a long-term reaction, and as pain and disability increase, the depression will often increase too. What happens with depression is that this is also going to hurt your ability to cope with information. You are going to have negative interpretations of anything that changes with your body. And under certain circumstances with this chronic illness, suicidal ideation or even attempts can be possible. And oftentimes what we're going to find is that a lot of people with depression due to this illness often don't get it treated because you're dealing with the bigger issue of the illness. So oftentimes this long-term depression due to the chronic illness may be overshadowed by the illness itself. Additionally, we know that there are some personality traits that affect our ability to cope as well. We know that all big 5 factors are related to coping in some way. Generally, if you're conscientious, if you're agreeable, if you're low in neuroticism, if you're open to experience, and if you're extroverted, that's going to affect coping in general and chronic illnesses in particular. In addition, we know that having high positive affect, generally being a person who is in a good mood, can generally be beneficial for people with chronic illness. Optimism can also help across a variety of different chronic illnesses. If you believe that things are going to work out for the best, that might actually give you the resources you need to cope. Now, oftentimes what we're going to find is that when you're dealing with a chronic illness, you are often going to be making comparisons between yourself and healthy people. This is what we would call an upward social comparison. And generally what we find is that for people who make those upward social comparisons, they tend to feel a lot worse about their illness and they feel less likely to cope in the long run. Generally, downward social comparison, thinking about people who are not as fortunate as you, can often be more beneficial to coping. So I am not telling you or forcing you to be grateful for what you have, but what I am saying is that if you're the kind of person that tends to compare yourselves to others when things are bad, consider the direction in which you're making that comparison. Upward comparisons generally make us focus on what we lack. Downward social comparisons often make us grateful for what we have. So now let's talk about the role that culture plays in chronic illness. So the environment that you grew up in can actually play a large role. And I got to admit, this is the part of the textbook that I really didn't like because they referred to basically families that deal with divorce as a broken family. And I'm sorry, me and my single parent family are not broken because my mom and my dad couldn't make it work. But one type of family structure, so they talk about extended families, blended families, nuclear families, but what we know in general is that the type of family that can be very detrimental to your health is a risky family. This is a family that has a lot of conflict and a lot of aggression. Generally, it's a very cold home, it's unsupportive, and it's prone to neglect. What we actually find is that growing up in a risky family can actually hurt your health, and it can actually age you. Risky families have been found to be highly associated with shorter telomeres. These are caps on the ends of genes, so that when our DNA replicates, basically, you only have as many replications as you have those telomeres. Shorter telomeres often mean sped up aging and poorer DNA replication. Additionally, growing up in a risky family can also impact chronic illnesses, often negatively. Additionally, your socioeconomic status really plays a role here. It affects the type of environment that you grow up in. Do you grow up in an area that is very prone to crime or is prone to poverty? Do you not have access to health care or insurance? So socioeconomic status will also affect your health over the long term and may actually influence the development of chronic illness as well. Additionally, ethnicity also plays a role here. So if we consider, for example, patient and provider cultural approaches to disease and illness, we know that this can be a factor as well. So we've talked a lot about the importance of patient-practitioner interactions, why sometimes language barriers can be very harmful, or how things like acculturation or immigration can ultimately affect stress and all of these changes that occur in people that are basically moving different places, moving to new countries. So we know that ethnic match can also play a role. Generally, people that have a practitioner that is the same ethnicity as them, those patients tend to cope better than if their practitioner is of a different ethnicity. Ideally, practitioners are also learning cultural competency to better help patients deal with different perspectives on disease and illness. Additionally, responding to chronic illnesses as a family may depend on your collectivistic or individualistic orientation. In a collectivist orientation, if one person in your family gets sick, it is the role of the extended family to help that person deal with that issue. Now, compared to individualistic cultures, oftentimes we're going to find that it is only the single person and maybe a spouse or a child or another family member, maybe one, who is helping with that care. In a collectivist orientation, the entire extended family is getting involved. We do know that religiosity also plays a role, and we know that religiosity does vary by ethnicity. Greater religiosity actually leads to more active coping, actually taking active steps to cope and adjust with a chronic illness, and this leads to better adjustment overall. And likewise, you and I have talked about how things like prejudice, discrimination, the presence of microaggressions can actually lead to worse health outcomes. So not only does it directly affect your health, but it affects the kinds of interactions that you have within the healthcare system, and this can potentially negatively affect your treatment and your health outcomes. Social support plays a huge role as well. Generally, what we're going to find is that social support leads to better adjustment. In general, if you feel like you're supported, if you have people who are helping you, you are going to engage in more active coping. And we do find that particularly if you are a part of a group that is low socioeconomic status, having more social support helps maintain quality of life. Now, there are going to be some cultural differences here. Depending on whether or not you are part of a group that is a cultural group that is unwilling to burden other people with your problems, you may be more reluctant to actually use that social support. So this is another instance where cultural sensitivity and competency is going to be important, because not everybody is going to want to burden other people with their chronic illness. And because of that, they are going to be less likely to use social support if they think they will be a burden on somebody. So now let's talk a little bit about different types of interventions that can be done. So generally, the goal of interventions are to reduce the biopsycho and social problems that chronic illness often will create. So oftentimes this will involve training patients to set different goals or modify the lifestyle decisions that they make to help them better cope with this new change in their life, to cope with this illness or to cope with the treatment. Now, this may also target caregivers because, as we know, caregiving for family members with chronic illnesses causes a lot of stress and can cause a lot of negative health outcomes as well. The treatment ultimately depends on the illness. So again, the type of treatment that you get depends on the nature of the illness. So for example, you might have more treatment options for something that can be cured like cancer compared to something like Alzheimer's, in which no cure exists. Another option when you're dealing with chronic illness, there is a lot of ambivalence. You're being forced to potentially change your life with a chronic illness, but you've been living your life in a certain way that you're accustomed to. There's going to be a lot of ambivalence, and there's going to be a lot of ambiguity. And this is where motivational interviewing can actually be really helpful. This helps patients explore their ambivalence and look at different ways that they can work with that ambivalence and change their behaviors. Now, other types of interventions might involve people increasing social support. And as I've mentioned, this generally does lead to better health outcomes, but too much can be bad. So your book talks about an instance where women who were struggling with breast cancer, they had their social support measured, and then they had to join a support group. Generally, what they found is that the women who already felt like they had a lot of social support, they actually felt negatively affected by the support group. They already had enough social support, and this was just one more thing adding to it. So generally, if you already feel like you have that social support, you don't necessarily need to go out and get more. Too much can actually negatively affect you. But if you feel like you don't have that social support, finding more support can be beneficial for your quality of life. So now we're going to talk very briefly about terminal illness before moving on to death. So terminal illnesses are anything that will be fatal. Oftentimes, chronic illnesses may become terminal illnesses. So Alzheimer's is a chronic illness, and it is also a terminal illness, although people who die from Alzheimer's do not actually die from the disease itself. Usually with terminal illness, oftentimes these people are going to be in the hospital. And if you've been to the hospital to visit a loved one who is very sick or dying, you know how hectic, how confusing, how tense the situation can be. There are visiting hours when you are allowed to be present and not to be present. Physicians are going to change. You might be talking to a variety of different types of healthcare providers. This person, if you're the patient, you are constantly going to be monitored and tested. And then not only that, you're potentially confronting your approaching death, and your family members are confronting that they're going to lose you. So it's often recommended that for people struggling with terminal illness, that psychological counseling is not just given to the patient, but also for the family, so that you can process the acceptance of death and you can help the family begin to grieve. Now, another thing that can be done with terminal illness is a focus on hospice. So hospice is often done for patients that are terminally ill, and the goal of hospice is not to cure. It is not to get you back to the quality of life you had before you were sick, but it's to maintain a better quality of life and palliative care. So removing pain, removing discomfort. What's really interesting is that for people on hospice, because the focus is on their comfort and on alleviating pain, you're a lot more likely to see people in hospice get regular pain treatment than people who are actually in a hospital. Another thing that we know is that for people in hospice, they are going to be more likely to die in the home than people who are in a hospital. And there's a lot of focus within hospice on patient autonomy and really ultimately making sure that the patient is comfortable. So now we're going to move on to talk about death and dying. And this is a very hard topic to talk about, I'm sure. One of the things that we know is that our religious beliefs, if we have any, affect how we respond to death and dying. And the views of death vary very much by religion. So your book talks about a few, such as the Hindu faith, and talking about karma and trying to live a good life to better your karma. But I looked up a few other examples. So for example, I'm Anglican. I'm Episcopalian. And according to that, when somebody dies, the Holy Spirit is released from the body. It is going to return to God, who is a triune God. The body is returned to earth that basically sustained it throughout life. The quality of the afterlife is based on how the dead lived their life. Many Anglicans believe that faith in Jesus Christ is a fundamental aspect of assuring an eternal life with God. Now, Catholicism is going to be a little bit different. So Catholicism also has this focus on an afterlife, on living a good life, particularly because Catholicism believes in the concept of original sin. But what's interesting is that the eternal part of the person may go to heaven, or they may go to purgatory, where unforgiven sins can be purified before reaching that afterlife. In the Islamic faith, what's actually kind of interesting about death is that death is defined as disintegration according to the Quran. And your book kind of mentions this. There are certain things that you and I might consider death that may not necessarily be considered death by other people. So I was actually able to pull up an article in the Journal of Religious Health. I'm sure that many of you are familiar with the concept of being brain dead. That means your brain is no longer functioning while your body is basically still alive, so to speak. Now, oftentimes when you're brain dead, your body is going to be on a ventilator because your brain controls things like heart rate, breathing, and if that's not working, that can't make the body run. So oftentimes people who are brain dead, they may be in something like a coma or a persistently vegetative state where their body is alive, but their brain is not. And depending on who you talk to, that person may or may not be dead. I actually was able to find an article that actually says brain death belongs scientifically within the spectrum of neurological disorders of consciousness and should not be confused with death. So there are a couple of Quran researchers that basically say Hindu death is not Hindu death. Dying according to the Quran is not the same as brain death. This is a very, very different thing. Additionally, we know for people that have religious faith, that is actually correlated with active coping, more active efforts to adjust to chronic illness. And we do actually find that for many people, religiosity does often strengthen closer to death. Now, let's talk a little bit about some of the different death causes across the lifespan. Oftentimes, what we're going to find is that death at birth is often due to birth defects. For accidents are going to be the most likely cause of death for children, adolescents, and young adults. Cardiovascular disease, cancer, and stroke, or cardiovascular heart disease, cancer, and stroke are often going to be the causes of death for older adults. And then there are some diseases like dementia that only occur in older adult groups. So what sort of things happen physiologically before we die? We know a couple of things. We know that your body is not going to be able to sustain itself. So things like urination and defecation are things that you may not be able to control. Additionally, things like salivation may not be able to be controlled. The digestive system will reduce its functioning. You're probably not going to be able to feed yourself if you're hungry at all, and there may be increases in pain. So you might receive some morphine to manage that pain. In addition to the physiological changes, there will be some cognitive changes. There will be difficulty concentrating, kind of having your awareness fade in and out, and additionally some memory problems. Now, this is a pretty controversial topic. People who are interested in facilitating death, particularly for people with poor quality of life or chronic illness, are focusing largely on patient autonomy. So we have different types of ways to facilitate death that are pretty controversial. So first we have euthanasia. Euthanasia is basically where somebody dies by administration of a legal drug. So basically, your book calls it an injection, but it really just is a drug. Now, euthanasia is basically an attempt to end somebody's suffering before it gets worse. Compare that to something like physician-assisted suicide, where the physician supplies the drug but does not administer. So euthanasia and physician-assisted suicide are different. Additionally, another way that death may be facilitated is by withdrawing life-sustaining treatment. So that might be pulling a breathing tube in the case of somebody in a persistent vegetative state, or maybe stopping chemo as a treatment for cancer because it's wrecking your body too much. But ultimately, and regardless of what you think about these different methods, what should be critical regardless of whether or not you are interested in using any of these methods is the autonomy of the patient. It's part of the reason why your textbook shows a living will, because there are probably certain ways that you would want to have your body handled or have your life be handled. And you should make those very clear to your friends and your family, because your family is going to be a key decision maker for many people's end of life care. So telling your family what your wishes are and expecting them to honor your wishes is critical. So I showed this at the beginning of class on Tuesday, a giraffe going through the 5 stages of death as he falls into some quicksand. This was very popularly developed by Elizabeth Kubler-Ross after interviewing hundreds of dying patients. And she tended to find that they went through the following stages: denial, anger, bargaining, basically trying to make a deal to get out of dying, depression, and then finally acceptance. Now, a lot of people note that you do not necessarily have to go through the stages in that proper order, and odds are pretty good you're not going to go through these one at a time. You might feel multiple of them at once, and additionally, there's not a lot of empirical evidence for their existence. So when you think of the 5 stages, take it with a huge grain of salt. Now let's talk about some of the cultural differences in death and dying. Now, one thing that I will mention that your book talks about that I think is very interesting is that in the Buddhist tradition, death is very much a part of your life. You are given life, you are ending, and basically because life is suffering, death is an end to that suffering. The cause of suffering is because of desiring things. And one of the things that I thought was pretty interesting is that they are very open talking about the nature of death. And generally, people tend to feel better when we talk about these things. They do not fear death, and that is very interesting to me. Cultures will ultimately vary in their emotional expressions of things like grief and loss. So you may experience this similar to what I have done. When I've gone to funerals for my family members, and I've gone to Mike's family's funerals for various things. And generally what I've found is you see a lot of differences. In my family, these are often a little bit sadder. In my partner's family, what we tend to find is that after the sad period and the church service and the burial, oftentimes there's going to be a couple of hours of time to gather with family and food and laugh and talk and celebrate the life of this person. So different cultures are going to vary in terms of their emotional expression of grief and loss. Think about some funerals you've been to and note the differences. Odds are pretty good there are some cultural differences there as well. Additionally, there are some different rituals surrounding death. And again, kind of that focus on cultural competence with healthcare providers and hospitals, these are really important. So for example, in Islam, after a body dies, it needs to be cleaned, turned to face Mecca, and there needs to be somebody nearby to actually read part of the Quran. With certain indigenous Americans, you may need to burn some sage, and obviously a hospital is not going to let you do that. And then finally, when we talk about death and grieving, there are some gender differences. Because women are often socialized, or anybody who is femme presenting, anybody who is basically female presenting is socialized to show emotion and be open with that emotion. As a result, women are often taken as the benchmarks of grieving, and anybody who is not grieving like that is basically assumed to be an abnormality. And this is a problem for people that identify as masculine because they often get less support. In general, widows get more support than widowers. And additionally, because people who are masculinely presenting are often socialized to not talk about their emotions, not grieve openly, not deal with their feelings, they often suffer more negative health consequences as the result of losing a loved one. So folks, this is pretty much all I had. I'm sorry it took so long. Watch it in chunks, and I hope this will help you prepare for your exam. I'll have a review session for you at some point over this weekend. Bye, everybody.